Hello, this is Dr. Al Ewer of A&T Lectures. Today, I'm going to talk to you about a very important ethical principle known as autonomy and how that principle applies both in the United States and abroad. The learning objectives for today will include reviewing the basic definitions of bioethical principles. We will specifically, however, focus on the ethical principle of autonomy. In addition, we'll look at how autonomy applies here in the United States versus other countries, and we'll actually use cases to illustrate these differences. Lastly, we'll provide you with additional resources should you want to actually delve down further on this topic. There are various definitions of healthcare and medical ethics that are out there in the literature. However, for the most part, they all refer to a system of moral principles governing the conduct of persons in a profession. In our case, the profession of healthcare, and more specifically, respiratory care or nursing. In addition, there's subclasses of ethics. Today's focus happens to be on ethics in clinical. However, there's also ethics that relate to medical research as well as medical education. If we were to open up most any medical ethics textbook, there would be 4 principles that would appear. These principles would include the ethical principle of beneficence, or that is healthcare which is in the best interest of the patient. The second principle is non-malfeasance, which includes actions or practices which avoid producing bad consequences. The third principle is justice, which relates to equity or fair treatment of patients. There are some subclasses of justice which focus on justice within a system, very broad level justice, or justice that applies to individual patients. However, the focus today is on the fourth principle, which is autonomy. And this medical principle relates to the right of the patient to govern the care, the right to evaluate various choices in their plan of care. As I alluded to in the prior slide, the general definition of autonomy refers to self-governance, or the right of individuals to function independently. It happens to be one of the principles that Americans hold near and dear. It is one of the principles that not only relates to ethics, but also is a fundamental building block of democracy. The medical definition refers to the right of patients to govern their care. In concert with that, in order for individual patients to govern their care, they need to be informed. So later in the presentation, we'll talk about the importance of informed consent in relation to autonomy here and abroad. However, it's important to note that in the United States, the law deems an individual's decisions about health care is indeed a right and is not a privilege. The presentation today will also cover that there are indeed some limitations, and that those limits tend to apply when an individual's autonomy interferes with that of another. In one or two of the cases we'll talk about at the end of this presentation, we'll illustrate how that applies. Drilling down further on autonomy. Autonomy at the bedside relates to the patient being told the truth about their condition. In addition, they should be informed about the risks and the benefits of treatments. For example, in the case of a bronchoscopy, the informed consent should include why the procedure is being done or the indications, what will be done, how that procedure will take place, how long it will take, what equipment will be involved, and things along those lines. The hazard should be discussed. The most common hazard of bronchoscopy is transient hypoxemia, which can be remedied with additional oxygen, and the potential benefits, whether it's removing mucus plugs so that the patient can oxygenate and ventilate better, and or taking samples of a lesion so those samples can be analyzed in order to determine the best treatment protocol. Autonomy also includes the patient's ability to refuse beneficial treatment. It could even be the right to die. And in certain states in the United States, as well as countries abroad, they allow physician-assisted suicide, which would absolutely fall under the umbrella of autonomy. The right of refusal, however, is not absolute. In the case, for example, of a patient who has newly diagnosed tuberculosis and begins a drug regimen which includes multiple antibiotics, patient's refusal to continue the therapy before it's completed places not only the patient at risk, but those who are around them. They could conceivably transmit a version of the bacilli which is highly resistant to the antibiotic regimens that are in place. So they may be subject to what's called direct observation therapy, where a clinician will go to the patient's home, or the patient will appear at a clinic, and the patient will be directly observed taking the appropriate medication. Another example of where the right of refusal is not absolute is, for instance, in a psychiatric rehabilitation unit where a patient is claiming to be suicidal, they could hurt themselves, or they are threatening to hurt those around them. In those cases, autonomy would be highly restricted in favor of protecting the patient and those around them. Over the past several decades, there's been a shift in the emphasis and understanding of autonomy in the United States. In the early 1960s, for example, researcher Donald Olkin did a study that revealed that 88% of physicians did not necessarily tell the truth to the patient when they had a recently diagnosed malignancy. The emphasis was on this paternalistic mindset that the doctor knows best and will be able to, if you will, call the shots or dictate the care plan for the patient. However, starting in around 1979 and 80, this has really changed considerably, the mindset. And this was illustrated in the work of Dennis Novak and others, who also did a survey that indicated that 98% of the physicians at that time now would tell the truth to the patient who had a newly diagnosed malignancy. This really illustrates a shift from a more paternalistic approach where the doctor knows best to one where, although the doctor and the healthcare team need to be involved, that the patient should be at the center, and we should respect the patient's right for self-determination. Now let's examine some of the limitations or barriers to autonomy in this country. Laws, for example, can restrict a patient's autonomy. Perhaps one of the most overt examples are laws that restrict physician-assisted suicide. Certain states in the United States do allow it, many do not. Likewise, abroad, a few countries, including the Netherlands, do allow it, but in many, many cases, most of the countries outside of the U.S. do not permit physician-assisted suicide. Another example of a barrier to autonomy are family dynamics, where the patient may not be competent, but the family cannot agree on the course of treatment. It may be the family cannot agree whether or not to continue mechanical ventilation on a patient who has catastrophic multiple system failure, perhaps secondary to sepsis, and the prognosis is extremely poor. Yet certain family members want mechanical ventilation to continue, and certain ones do not. Another example are restricted health insurance policies. Increasingly, many Americans are now selecting cheaper health plans. In some cases, their employers are selecting those plans. In other cases, Americans are going into the exchange, and when they see the cost of some of these plans, they're selecting cheaper plans. However, with less expensive plans come more limitations, and with those limitations come restrictions to autonomy. A fourth example is organizational policy. Some hospitals have removed or frankly, have never placed certain medications on formulary. One of the examples is when Xopenex came out, many hospitals had Xopenex or levalbuterol, cousin drug or an analog drug to albuterol, but it's much more expensive. And when hospitals examined the cost profile, many of them took it off of formulary. So individuals who wanted to receive levalbuterol could not do so in the hospital unless they, for instance, brought it from home and the doctor and hospital permitted them to do so. Now, let's examine some of the barriers that exist to autonomy in other countries. In order to do so, it's important to understand that the healthcare systems in many other countries are what's called single-payer systems. And that is, there's one entity, often a governmental agency, that regulates the financing and the overall restrictions on what's covered and what's not. In doing so, that tends to limit the patient's choices. Again, unless they have supplemental private insurance. A couple of examples would be in certain countries abroad that their approach or protocols to heart disease, for instance, congestive heart failure, would be more conservative, would emphasize pharmacologic treatment, dietary restrictions, perhaps appropriate exercise, and things along those lines, instead of more broad use of more expensive interventions such as surgical approaches, coronary artery bypass, or the interventions that exist for heart disease in the cardiac catheterization lab. It's not that these procedures are never done in other countries, but they tend to be done less frequently than in the United States. Another example is fetal care. Take the patient we just referred to in the prior slide who has catastrophic multiple system failure secondary to sepsis. In other countries, the care for them will be more limited, and that is the patient and their family will not have the final say. And at some point, the government or the agency will step in and say, this is deemed fetal care. We will, of course, keep your mother on the ventilator or your father or your loved one on the ventilator for another X number of days, but at that point, they're going to be removed unless you wish us to transfer your mom or dad to another facility that's covered by your private insurance. Therefore, citizens in foreign countries tend to have more limited autonomy unless they have the supplemental private insurance. In looking in more detail at barriers to autonomy abroad, it's important to distinguish between developed and developing countries. And the two developed countries that I focus on in this presentation are Canada and the United Kingdom. So in Canada, monies are taken from payroll taxes. They're collected in a central repository and they're allocated to the provinces. In Canada, provinces are like states are in the United States. And so these provinces get a certain amount of money through what's called the Canada Health Transfer. However, when monies run low for certain procedures, or in general, if you will, care is triaged and non-life-threatening illnesses often must wait. This is a major restriction to patients' autonomy in countries like Canada. In the United Kingdom, similarly, they have a single-payer system. However, unlike Canada, healthcare is run by what's called the National Health System. It is a branch of government. Most physicians, most nurses in the UK are employees of the National Health System, unlike in Canada, where they're not, where they're independently functioning with either private, not-for-profit, or private for-profit hospitals. However, in the UK, when monies run low with the National Health System, autonomy is restricted in a very similar way that it is in Canada. It is also important to look at barriers that exist in developing countries. Many of these countries lack an organized healthcare system. That itself can restrict autonomy. That structure, that lack of process, the lack of a framework can be very limiting on autonomy. Looking at China, for example, although they claim to have a unified system, that unified system seems to apply more towards those in the middle class or higher, often those who reside in the city have good jobs and therefore have good access and choices. Their autonomy would be pretty good or very good. However, in China, rural dwellers are actually quite vulnerable, and they're at the opposite end of the spectrum, many of whom have very limited autonomy. In the rural areas, they're generally restricted to medical services offered by local undertrained providers, and therefore that in and of itself limits their autonomy. These next 3 slides give a very brief overview of the healthcare systems in Canada, England, and China. As I alluded to previously, because of the high level of decentralizations, provinces have primary jurisdiction in Canada. They receive money from the central government based on population or a per capita basis. The Canada Health Act is the law that sets standards for what's necessary, what's not, reimbursement levels, physician services, and things along those lines. Perhaps most significantly, healthcare expenditures are about 11% of gross domestic product versus about 18% in the United States. Per capita health spending is approximately $5,500 annually versus in the United States, which is almost about $10,000. Supplemental private insurance, which I also mentioned previously, is held by about 2/3 of Canadians. And then there's these, if you will, safety net programs that are out there for instance, cost sharing exemptions for low income seniors and other vulnerable populations. The English system is similar to the Canadian system in that health services are provided free of charge to all citizens and legal residents. However, unlike Canada, the English system is much more centralized. Healthcare is financed and regulated by an agency known as the National Health Service. Regarding expenses, the UK spends about 9% of their gross domestic product on healthcare. Again, much less than we do and just slightly below what Canada spends. Funding comes from general taxation, and about 11% of the population have voluntary private health insurance to supplement what's provided through the government. China also has a centralized way of financing, legislating, and administering their healthcare system. It's overseen by the National Health and Family Planning Commission. China spends about 5.6% of their gross domestic product on healthcare. However, like I alluded to before, in urban areas, those that have decent jobs or middle class or higher tend to have good coverage and access regarding healthcare. Their choices and their autonomy tends to be fairly good. However, in rural areas, that is not the case. Primary care is mainly delivered through village doctors who are not necessarily licensed, can only work in village clinics, and have very limited training and resources. Therefore, rural dwellers in China have very few choices, and their autonomy is quite limited. In examining autonomy abroad, it is also very important to look at countries that are developing and lower income countries. These countries tend to be more utilitarian out of necessity. Ironically, they're not heavily afflicted with issues which plague countries such as the United States, Canada, England, and other developed countries. They're not plagued with overutilization. They're less plagued with feudal care and choices regarding it. They tend to have a better handle on ethical considerations regarding end of life, when and what to ration. In some cases, the choice to ration is simply a function of not having the necessary resources. Interestingly enough, several African countries, including Mozambique, Rwanda, and others, they have a high disease burden and they have relatively few health resources. However, they are really leading some models regarding palliative care and best practices that relate to palliative care, as well as end-of-life choices for patients. This slide talks to futility, its definition, and the difference regarding fetal care in this country versus many other countries. So the objective criterion for fetal care, which is pretty much universally accepted, is conditions which are associated with less than a 1% chance of a meaningful survival. And meaningful does vary from individual to individual, but we're talking about with regard to cognition, with regard to quality of life and things along those lines. Some examples would include profound head trauma, brain death, and things along those lines. In this country, as I alluded to previously, the decision to continued care in these circumstances is generally governed by the family, which is different than what really occurs in other countries, where the payer, often the government, really has a very prominent say in the continuation of care over the long run. At this point, it's probably a good idea to take this presentation away from theory and talk about practice. Talk about how autonomy applies here and how it specifically applies abroad. Let's start with the United States and let's look at a very particular doctrine known as the mature minor doctrine. So in many cases, an individual who is not emancipated, who is not 18 or 21 years old, does not have the final say, and their parents may have the final say as to whether or not certain therapies should be continued, initiated, modified, etc. However, in certain states and under certain conditions, the mature minor doctrine applies, where a older teenager who's not necessarily 18 or 21 nor emancipated can have the final say and can usurp the wishes of their parents. They can truly have autonomy with regard to whether or not they want to continue certain therapy, modify certain therapy, pursue an alternative one, such as in the case of certain types of cancers, cystic fibrosis, and other diseases. Case 2 illustrates a situation that we alluded to earlier. Again, a patient who has tuberculosis, who is on multiple antibiotic therapy, and they're on that therapy for some period of time. They're feeling better, which in many cases they will. And after, let's say, a month into a 6 or 9 month regimen, they decide they're not going to take it anymore. So, as we said, even in the United States, autonomy has its limits. If patients are deemed a threat to themselves or to society, others, then they can be actually mandated to take certain therapies, including, in this case, their antibiotic until it's finished. This is known as direct observation therapy, where the individual will either have a clinician report to their house and visually see them take the medication, or the individual will report to a clinic where that will happen. And many times that the patient, if they're on, for instance, assistance from the government, that their assistance will continue only if they comply with direct observation therapy. And this is an example of how autonomy can be limited in this country, but appropriately so, to protect others. This case describes a major limitation to autonomy in this country, and unfortunately a phenomenon that's occurring with increasing frequency. In this particular instance, an Ohio man sought treatment from a major hospital system in the southern United States for lymphoma. As it turns out, he and his wife actually had a less expensive, but also a policy for health insurance that did not provide very good coverage. He was told by the hospital system from which he was seeking treatment that they didn't take that kind of discount insurance. Consequently, the patient had to ask his mother to help underwrite the costs. So she wrote a check for almost $50,000 to the hospital system. In addition, that hospital system asked him to put a $7,500 hold on his credit card to cover expenses that would exceed the check that his mother was writing. This particular example basically shows that the United States is one of the few countries where individuals can go bankrupt from these uncovered expenses. In this case, the total cost was almost $84,000. And this couple ended up receiving the treatment, but they also ended up with a very significant hospital bill, which they were left to pay off over a long period of time. This case is just one of many examples of how insurance limitations can limit a patient's autonomy and ability to make medical choices. Consider for a moment if this couple did not have access to such funding and what that would have meant in terms of his inability to receive the necessary treatment and perhaps succumbing to a potentially treatable disease. This case speaks to a fundamental process and instrument for autonomy known as informed consent. And informed consent is a very descriptive term. It speaks to the patient and or decision maker should be informed as to what's being done, why the procedure is being done, what it entails, what are the potential hazards and contraindications, as well as what are the potential benefits. And patients who are in a compromised status, who are cognitively not intact, such as those receiving moderate or heavy sedation, should not be queried regarding informed consent. The process should either be delayed or their power of attorney or surrogate should be questioned instead. Failure to do so doesn't just undermine informed consent, it undermines the fundamental principle of autonomy, as well as the concept of patients being able to make informed choices. This fifth case illustrates how the United States is so very different than many other countries when it comes to fetal care. In the United States, in general, care will continue for patients who, for example, have a profound head injury until the family decide that the patient no longer should receive that care. For example, in the case of a patient who has a profound head injury and is on mechanical ventilation, that mechanical ventilation will continue until the family decides that that care should be withdrawn, almost irrespective of the patient's prognosis over the long run. This is very different than what happens in other countries. In many other countries, while immediate care will be given, and for a patient such as this, they may well be started on mechanical ventilation, that care is not limitless. And at some point, it will be made clear to the family by the payer, by the governmental agency and or the hospital, that care will be imminently discontinued unless the family wishes to private pay or they have supplemental insurance. While this may seem inhumane and insensitive, it's also an example of whereby providing fetal care may not be appropriate and may not ultimately be in the best interest of the patient over the long run. This case, entitled International Case 1, illustrates some limitations to autonomy in Canada. This particular patient was fighting cancer, but ended up having to fight her government to receive a proven cancer drug that more eloquently targets cancer cells than an alternative treatment that crudely kills all fast-growing cells, including ones that are healthy. The patient received several rejections from the Canadian government. However, on further investigation by the patient, found out that this particular medication, Erbitux, is a standard FDA-approved treatment in the United States, and found this information out through an affiliate hospital in the United States, in actually Buffalo, New York. Eventually, an ombudsman ruled in the patient's favor. The ombudsman is actually a system they have in Canada to permit patients to actually appeal rejections. And in this case, the ombudsman, with all the information in hand, most notably that this was an FDA-approved treatment in the United States, ended up ruling in the patient's favor. Now, this was after several months, so the patient actually had to delay their therapy for that period of time. The patient ended up getting the therapy and ended up responding to it, but it was still a delay, it still caused a lot of stress and angst for the patient and their family. It represents a dramatic new trend in the Canadian healthcare system. It relates to advocacy, finding the treatment you need in another country, and then fighting the Canadian bureaucrats to get them to pick up the tab. This whole process is a huge limitation to autonomy for the Canadian citizens and represents a significant shortcoming to single-payer systems such as that in existence in Canada. International Case 2 relates to India. It broadly relates to a country that's made a lot of progress. It's developing, their economy has really come a long way, their healthcare system has come a long way. Still, in relation to many other countries, they have limited resources. And it forces their healthcare system and the people within it to make some very difficult choices. Simply put, there's not enough dialysis, there's not enough kidneys, there's not enough hospitals many times in order to serve every need. And in the case of patients that are fighting kidney disease, some difficult choices unfortunately have to be made regarding patients who receive dialysis and some patients who don't. The decision becomes even more difficult when it relates to who gets a kidney to be transplanted and who doesn't. So even fewer kidneys that are available, period, but particularly within countries such as India. These are very difficult choices, but again, limited resources forces them to be made. These sorts of choices or lack thereof are a major limitation that exists to autonomy for patients in developing countries, such as India. International Case 3 speaks to an interesting twist on autonomy. It relates to a country that does permit physician-assisted suicide, the Netherlands. And a study has shown that about 1 in 5 individuals that seek physician-assisted suicide in that country are at least partially seeking physician-assisted suicide so as not to burden their family with expenses and the direct burden of patient care. So it illustrates how a country that actually has a single-payer system and permits physician-assisted suicide in a very kind of odd way supports autonomy, but supports it for a purpose for which it was not initially intended. International Case 4 has a couple of interesting dimensions to it. One of them is it's yet another example of how direct observation therapy can be utilized to successfully address a societal issue, in this case, tuberculosis in China. Now, in this presentation, we've talked about how direct observation therapy has been used in the United States, and it's been used successfully in order to reduce the prevalence of tuberculosis by enhancing compliance with drug therapy for tuberculosis. It's also been used to increase compliance for treatment of sexually transmitted diseases here in the United States, as well as HIV and other diseases as well. The other interesting component to this case is it shows how countries can learn from one another, how China looked to other countries, in this case the United States, to address an issue they had regarding tuberculosis. And it turns out that the whole issue of tuberculosis and the disease prevalence in that country is much greater than what it is in the United States. Still, with that in hand, the Chinese looked at approaches that we were using and, if you will, borrowed them to successfully reduce the prevalence of tuberculosis by about 40% in their country. So while they were limiting autonomy, they're also addressing a societal issue and, if you will, protecting the beneficence and autonomy of their greater population. This last case illustrates a theme we've talked about throughout this presentation, and that is that indeed the Chinese healthcare system is the tale of two cities. Those Chinese citizens who are becoming middle class or more affluent are apt to have very good care. They will tend to have, for this particular case, an individual who has heart disease will have the appropriate testing, which will probably include a nuclear stress test, appropriate medications, and access to a cardiac catheterization lab and bypass surgery. The prognosis is probably fair depending upon the degree of congestive heart failure that this patient is experiencing. The rural farmer will probably receive an herbal remedy from a local undertrained doctor, will not have access to a lot of the medications, probably not have access to the diagnostic stress testing, nor the invasive procedures such as the cath lab or bypass surgery. And their prognosis is poor to very poor as a result of this dichotomy that exists in China and many other developing countries. So in this respect, the Chinese, like other developing countries, have a bifurcated level of autonomy, with those who are more well-to-do will have an extensive amount of autonomy, and those who are not well-to-do will have a very limited amount of it. There's a few take-home messages and central themes that I want to leave you with. One of them, and perhaps most importantly, is that autonomy is a key bioethical principle, which you would likely find in most any bioethics textbook that you would encounter. Autonomy involves self-governance, and it involves informed choices. Because of that, the informed consent process and document is a key strategy that's used to support autonomy here and abroad. However, autonomy has its limitations as well as its barriers. Some of those limitations relate to when a person's autonomy may have a negative impact on those around them, such as we've discussed with the tuberculosis example, but basically with many communicable diseases, autonomy, it comes into play. The barriers are numerous. The barriers often, however, tie back to the payer. Here, the payer many times are private insurance companies. Abroad, particularly with single payer systems, they're either the government or they are a branch of the government or an agency that oversees or is charged with financing and administering healthcare. Autonomy tends to be more limited outside of the United States. And I had those few slides that actually talked about the healthcare systems in Canada, in the United Kingdom, in China. All of them spend less in terms of a percentage of their gross domestic product, as well as per capita expenses versus us. However, what they get in exchange for that is fewer choices. However, in the United States, things are also changing. So many efforts, not just the Affordable Care Act, but as many efforts to try to reduce healthcare spending in this country, which is again currently about twice that of some of the countries we talked about today, including those developed countries, Canada and the United Kingdom. So Americans are also attempting to choose cheaper but more restricted healthcare plans, which again, while saving them money, will also restrict their choices and autonomy. Understanding autonomy here and abroad can help us appreciate our system and the choices that we have. Probably most significantly is more information is available for those desiring to know more about medical ethics and in particular autonomy. The references in the following slide can be a good starting point for those wishing to learn more about this and related topics. For those desiring to learn more about autonomy here, autonomy abroad, or just medical ethics in general, these are some selected references. Lastly, we want to really thank you all for sitting in on this presentation. We hope you enjoyed it, and we appreciate your feedback in terms of evaluating it as well as our other presentations. Thank you very much, and have a great day.